factors, but sometimes, we neglect to consider those when we're first screening and then assessing one of our consumers. Along with that, of course, is understanding the cultural context that the client is coming from. Are there any natural support systems that we can enlist to assist the client? As mental health professionals, we want to understand that we're there to work with the client, increase their motivation, increase their ability to successfully complete their treatment plan, but we can't do it all by ourselves. So, of course, in the time of integrated behavioral health care, we'll talk about that. We want to enlist what other disciplines are available to help us with the client. But additionally, we want to look at their cultural context. Is their cultural context something that encourages their treatment and recovery, or are there cultural factors that actually work against their treatment and recovery? Uh, Family, of course, can be either something that assists the process or sabotages the process. Cultural institutions like religious, kinship, spiritual relationships is something that can enhance recovery and treatment, or again, work against recovery and treatment. Um, what are some of the cultural contextual issues that you and I need to be aware of? And since all of you have been studying and working in this field for a while, you're fully aware of how a lot of co occurring disorders, substance use disorders, mental health disorders are a result of trauma that our clients have experienced, usually, but not limited to, early events in their lifespan. Of course, there have been famous studies, including one that came out a couple of years ago, longitudinal studies on the impact of adverse childhood experiences, not only mentally, but even physically on our client population because of trauma that they've experienced. And if our clients are from a marginalized population, they've not only experienced individual trauma, but they've also experienced communal trauma as being part of a marginalized or oppressed group. So, in doing our screening, assessment, and even treatment or service planning, uh, how does the individualized experiences of trauma fit into the outcome that we want to create in collaboration with the client? Which, of course, means we have to look at the elements of trauma informed care. How, in working with the client, are we not only culturally sensitive, but also sensitive to how they've experienced trauma on an individual, communal, or cultural nature? And how can we utilize those modalities and techniques to enhance our clients being successful? Um, we have recognized trauma, of course, but some of our colleagues and maybe some of our institutions are not trauma informed care socialized. So, of course, that's one thing you can assist with as you become teachers, trainers, supervisors in the environments where you work. So, I've talked a little bit already. We're about 15 minutes in. Any questions, comments, or concerns about anything that I've said so far? Is that unanimous silence I'm hearing, Dr. Rivas?
Yes, sir. At this point, yes.
Okay, well, I'll continue on. Um, in the past 12 years, we've learned more about the brain through explorations in neuroscience than we have probably the entire time of our species before. And one of the ways that science informs how we work with our client population is it's shown us the relationship between addiction, brain science, and neuroplasticity. The consensus has been everywhere from the federal level to the local level that addiction is a brain disease. uh, Addictive processes and addictive substances capture the reward center or the pleasure center, the literature calls them both, of our client population. And that's what makes addiction such a difficult thing to treat. The brain has been tricked to believe that engaging in the addictive process, pornography, sex, gambling, internet, eating, is essential for the survival of the organism. So, just like eating and having sex, the brain believes that though the addiction is essential to the survival of the organism and even the survival of the species. So that makes it additionally challenging when we work with the client population. So, additional training and understanding of addiction as a brain disease is essential to developing clinicians that are working with SUD, MHD, and co occurring disorders. Some of the research has shown that the prison population, in addition to being populated, as we know, by poor people and people of color and people that don't have a high school education, the studies have shown that people with traumatic brain injury and other organic dysfunctions are the majority of our prison population in the United States. And of course, in the United States, we have 3 million people in the criminal justice system, federal and state. The United States has the highest rate of incarceration in the world in proportion to the population. And we're only now realizing how much of that is related to issues of mental dysfunction, though we have known for decades substance use disorder is a great contributor to that. So, understanding how we can use neuroscience to assist our client population is a scientific area that's been established, supported by research and evidence, and a growing responsibility for you and me to understand as practicing clinicians. Which brings us to point seven, the relationship between substance use disorders, process addiction, mental health disorders, whether they're mild, moderate, or severe in the quadrant of care, and as I mentioned, the criminal justice system. Because we have changed how we view addiction as a brain disease, um, we are concerned that clinicians trained to work with the population and co occurring disorders have an understanding of how these things interact with each other. Just about every substance use disorder client has a mental health disorder. Just about every client with a mental health disorder has a co occurring addiction, be it process or substance. And some particular disorders overlap quite a bit. Schizophrenia and schizoid affective disorder, depression, post traumatic stress disorder, anxiety disorders, and the personality disorders, borderline and bipolar, have a high overlap because of the tendency of clients with mental health disorders to self medicate by utilizing substances. So, when we talk about training and counselor development, we're talking about the necessity for our practitioners like yourselves and academicians like yourselves to understand the symbiotic relationship between addiction and mental health disorders. Which brings us to one of the points of this conference. How do we remove attitudes of stigma, attitudes of moral judgment by people with these issues who are seeking some type of professional assistance? So, in many ways, like in culture, the one thing we do is work on changing language and eliminating false assumptions. There's been a movement that's, at least 15 years old to reshape the language that we use towards clients with substance use disorder. For example, changing language like a urinalysis being dirty or clean, which also implies, of course, that the person is dirty or clean, and instead using language typical of other medical assessments, such as positive or negative. Stop calling people addicts or junkies and talk about folks with substance use disorders, which sounds like, of course, other medical disorders that individuals have. We don't label people as heart attacks or kidney diseases. So, trying to humanize the language more and take away this stigma and moral judgment that has been so much a part of Americans' culture towards persons with addiction issues. So, one of my mentors once said, if you want something to live, you call it a flower. If you want to kill it, you call it a weed. Language is important, as the social constructivists and the feminists have helped us to understand over the decades. So, changing our language about the client population that we serve is an important factor in humanizing what we do and increasing the chances clients will be more motivated to successfully complete their treatment program without initiating personal and social shaming as part of the therapeutic culture. And of course, in our time of integrated behavioral health care, different healthcare related professions working together to assist our client population has become more important. As clinicians, we can use talk therapy and the expressive arts therapies like art therapy, play therapy, sand play therapy, storytelling, poetry therapy to assist our client population. But the reality is, because of some of their neuroscience related issues, some of their issues are organic. And talk therapy by itself, narrative therapy by itself, or expressive arts therapy by itself cannot alone assist them in the manner that they need. So, learning to work with our clients from a multidisciplinary perspective without issues of territory and silos is another movement that we need to make in supporting our client population and changing the attitudes of counselors. Dr. William Miller, who developed motivational interviewing using the ideas of my old teacher in California from the 80s that I trained with, Dr. Carl Rogers, said that counselors are often more resistant to change than clients are. So, changing counselor attitudes about these issues, as well as changing attitudes professionals have about working together, is part of the development of integrated behavioral health care and our multiple disciplines working together. So, before I head to the next point about training, clinical supervision, and service evaluation, I want to stop again because I'm a therapist. I have to check in. Any questions, comments, or concerns at this time? Because we're almost halfway through. Dr. Rivas, any?
I've got nothing in the chat. Uh, okay, so I got a question. They're starting to flow in. Okay. So one of the questions was, could you give an example of what you mean by process addiction?
Of course I can. Processes like sex, gambling, internet gaming, pornography viewing, eating disorders impact the same part of the brain that substances do, like alcohol, cocaine, or THC. So persons can become addicted to processes in the same way that we've seen people historically addicted to substances. And of course, for some of our client population, they have mental health disorders, substance use disorders, and process addiction issues. The person that has a concern about their body image and uses meth in order to stay thin. The person that has an eating disorder and abuses diet pills in order to stay thin. The person that goes to somewhere like Las Vegas and engages in alcohol use and gambling at the same time. So the research has shown that processes can be just addictive in the same manner as substances are. Does that answer your question? You're welcome. Okay, I see 7 notices in the chat, Dr. Rivas. So, um,
Oh, yes,
questions at this time?
there was a few thank you about emphasis on language and power it has. And thank you for mentioning ACEs and trauma-informed care. The other question, what would be the best way to reframe the language used, such as overeater or porn addict, etc.? Um, and it says, I'm asking for maybe a specific set of words.
Oh, that's a very good question. Thank you. Um, the first way is to begin to inform our profession in the same way we're discussing it right now. As Dr. Rivas mentioned, since 1995, my wife, Dr. Evelyn, and I have directed what in Colorado is called a private occupational school. And we've been training mental health professionals in our state and some others for certification and licensure. So, starting this discussion where you and I are is the best way to begin the process. And actually, I'll have Dr. Rivas post my email address. There's some articles that have been published that talk about specific language suggested to talk about our client population now. Oh, yeah, it's at the top of the handout. Thank you. Um, so if you email me, I'll email you some of those articles, and they actually have suggested terms for usage. One of them is very interesting. It came from Alcoholism Treatment Quarterly, and it even calls itself which is kind of catchy, an addictionary, talking about different vocabulary we should use about addiction, explaining why some words are harmful, judgmental, and actually detrimental to treatment, and suggest some other words we use like substance user, patient, or just consumer or client. We have to ask ourselves, why do we feel there's a necessity to single out someone with addiction issues and describe them in different ways than we have with other people that we work with mental health and medical disorders? Okay. Does that answer your question?
I believe, yes, it did.
Okay, thank you very much. Okay, Dr. Rivas, other comments or questions I need to address before we move on?
Just a comment saying thank you for mentioning ACEs and no other questions at this time.
Okay, good. Well, let's continue. Um, the next point kind of brings to mind the question that was asked about how do we change the language. Um, we have to start with clinically appropriate training. Historically, people that dealt with mental health disorders only learned about that, and people that only dealt with addictive disorders only trained in that. In at least the past 10 to 12 years, there's been a movement in our profession to have people cross trained in both areas of human challenging. So if that's not happening in your environment, then that's something you want to encourage to happen. And people that have been cross trained providing clinical supervision. The appropriate role of a supervisor is to socialize a junior colleague into the profession. So we have a saying in the African American church: you can't lead where you don't go, you can't preach what you don't show, and you can't teach what you don't know. So if you, as a clinical supervisor, hasn't had the clinical training required for people entering the profession now, you need to go get it yourself so you can pass that on in your supervisory responsibilities. And then something, even as supervisors, Dr. Rivas and I hate to do sometimes, but evaluation of the services provided. If you're an administrative supervisor or a clinical supervisor, you want to make sure that if you're providing the training is being implemented in a way that assists the client population. And your clinicians are not still working from a paradigm that's essentially obsolete in 2021 as we're working with clients with co-occurring disorders. So there's some basic factors around that. You and I want to make sure that the therapy we're providing and the education we're providing, and some of you are both clinicians and educators, like both Dr. Beta Rivas and Dr. Anthony Rivas, that the information is research based. The whole purpose of science is not just for us to reflect and contemplate on this in our profession, but how do we take the science to better enable what we do as professionals and assist our client population? So you want to make sure that the approaches you're using are research based and evidence based. And there is scientific support that shows that what you do works for the client population that you're working with. An additional necessity is that the therapy be goal driven. What's the goals of the client population you're working with? And how much of the therapeutic relationship is collaborative? Um, in many institutional sessions, the therapy is often professional driven rather than client led. So the nature of our profession is it's supposed to be collaborative, not coercive. So what are the goals of the clients that you're working with, and how well can you facilitate successful completion of the treatment goals? Studies have shown that clients have 85% of the piece, and you and I have 15% of the piece in terms of accomplishment of therapeutic goals. So making sure your approach is aligned collaboratively with the clients you're working with is a very important piece. And related to that, of course, which motivational interviewing talks about quite a bit, so does CBT to a lesser degree. It's what's the value system of the client that you're working with. And even though the goals may be collaboratively drawn up, are they consistent with the values that the client herself or himself feels are important in their life? The research has shown that if you can align your treatment with the client values, that enhances client motivation and enhances client success in completing their treatment goals. And as I said earlier, the approach has to be integrative. One of the false assumptions of the profession is that clients with substance use disorders somehow have to have those eliminated first before they can have mental health related work, or that clients with mental health disorders have to first have those issues solved before they can address their substance use disorder issues. The research has shown that the best way to do it is an integrative approach where you're addressing all the issues that the client has at the same time. Of course, you may need to prioritize depending on your level of competence, the mission of the institution, and the presenting needs of the client. But research has shown that addressing them both, uh, substance use disorders and mental health disorders together, co occurring disorders, is the way to be most successful in working with the client population. Those of us in the field talk about skills and pills, that we have to help our clients develop the necessary coping skills to improve their lives. And at the same time, if there's an organic nature to their disorders, work with them with the appropriate pharmacology, if possible, to assist that. So, in our contemporary clinical environment, we work with clients with psychotherapy, psychoeducation, and, if necessary, psychopharmacology, and integrate all elements of that together to assist the client in improving their lives and completing their treatment goals. So let me stop at that point and ask again if there are any questions, comments, or concerns. I see we have 33 participants.
We do have
Sure,
one
there have to
question.
be some questions or comments that our colleagues want to make, Dr. Rivas.
We have one question that came in
Okay.
that said, and this goes back to the languaging, Dr. Leslie.
Sure.
It's the goal to change the language the patient uses about themselves, or is it the goal to change the way the healthcare providers speak about them, or is it both?
It's
And to add on to it was thinking about the languaging that many 12-step or self-help groups use. So kind of in that package.
Okay, a two-part question. So my own neuroplasticity only allows me to answer one question at a time. So I'll answer the first, then I'll answer the second. The first is yes, it's both and, because our client population has been shamed and experiences so much guilt. Helping them change their own perspective about themselves is important, as well as it's important for the clinicians to change their perspective about the treatment they're providing. I had a client one time that always described herself as having to be strong in her family system. And after, we had enough sessions to develop the kind of rapport, I told her, the image I get when you say strong is a pack mule, someone carrying a burden. Um, what would you think of yourself if you exchanged the word powerful for strong? And over a course of 3 sessions, even her body language changed. She would come to session with her shoulders slumped over, like she was literally carrying a burden, but giving her the homework assignment to change the word powerful for strong, she, just over the course of 3 sessions, would begin to sit up in the chair rather than lean over like she was carrying a burden. So the social constructivist models in marriage and family therapy And other models have taught us that changing the language actually effectively changes the brain in multiple ways in working with our client population. Now, the second question about peer support and AA, I can't address that because peer support groups are not professional psychotherapy. And since 1979, the addiction counseling profession has worked very hard to separate the distinction between peer support, which does not involve professionals, and professional treatment of substance use disorder by people at our education and professional level. So the self-help groups and the peer support groups, they're going to have to address that on their own. But I guess discussing the dichotomy between that when you work with your clients is a helpful way to kind of make that distinction. You are not a AA sponsor. You're a mental health professional. So your role in their lives is significantly different. Uh, does that answer your question?
I believe it did answer the question. Yes, sir.
Okay, good. And that's the thing that comes up. When I was working with clients much more than I am now, I started working with clients with substance use disorders in my 20s. They would often ask, had I ever been an addict? You have to make a decision about how you address that question in terms of self disclosure. But I would go ahead and answer and told them no. I have never been a substance user. I told them when I was growing up, they called it dope, and I did not consider myself one. And often they would say, well, you can't be my counselor because you haven't shared my experience. And I would say, let me make something plain. I have spent my entire lifespan making decisions so I did not have experiences like yours. The issue is not my past. The issue is your present and your future. I can model sobriety, which is what you really need. If you want someone to share your experience, then you go to a 12-step group. I'm not your peer. I'm a well educated mental health professional. And that's my role in what I do. And a lot of that is tactical. Uh, we don't like power differentials. And since counselors have more power in a therapeutic relationship than a consumer, it's a tactic. They often try to equalize power. If they can make the therapy about you're not being good enough because you haven't shared their experience, then you spend your time trying to prove to them you're a good enough therapist rather than holding them to their treatment plan. So I peeped that in my 20s, not something I feel I have to apologize for, never being a criminal or never having an addiction. Okay. Any other questions, comments, or concerns?
I have a question, but I'm I'm driving, so I can't type out my question if I may ask it.
Of course, you may ask it.
Um, so I know there are quite a few treatment facilities that solely focus on the treatment of addiction rather than the co-occurring mental health issues.
Uh huh.
And I was wondering if you had an opinion or any insight as to if more of these facilities are going to start gearing towards a more holistic approach rather than just treating, going in, detoxing, putting them on a supplemental medicine to help wean them off of their drug choice and, try kind of delve deeper into more of the counseling aspect as well as just the treatment for the drug use. I don't know if that made sense as I was saying
Oh,
it.
it made a lot of sense. I'm going to have to ask permission for you to allow me to reframe it so I can answer it.
Yes, please do.
Okay, good. What I hear you asking is actually two separate questions. So, again, I'll deal with one at a time. First thing you were asking is my opinion of treatment facilities that only address addiction. The research has shown they're not as effective as those that, as you imply, treat the whole person and treat the whole realm of the clinical issues that they have. The research
Mhm.
has shown that facilities that treat the mental health disorders and the substance use disorders are more effective for the client long term, particularly since, depending on the substance, it can take people 90, 120 days to have their brain begin to recover from the substance they abused. The second part of your question was, do I see things moving more towards holistic treatment? My answer to that would be yes, but unfortunately for a lot of our clients, it's not happening soon enough. So those of you that have signed on for today, I'd like to see y'all take responsibility as much as you can, considering the power dynamics in your institutions, to try to speed that process along. If you're an academician, teach it in your classrooms. If you're a clinical supervisor, begin to socialize your clinicians into it. If you're a clinician, try to integrate it into your therapeutic practice with your client population. If you're in a facility where y'all take turns doing 1 hour or 2 hour in service trainings for each other, included on your agenda to train your colleagues and peers on the very issues we're talking about today. Okay. Does that answer your questions?
Yes, absolutely. Thank you so much.
You're more than welcome. Okay, I see we got about 15 minutes left, Dr. Rivas. I want to stop and see if there are any more questions or comments before I move to wrapping up, and then we'll still have time for Q&A. But I like to pause, and I get intellectually stimulated by the questions rather than just presenting an academic template. I know you do too. So, any other questions, comments, or concerns? Okay. Stone silence. Any type in there into the chat room, Dr. Rivas?
No, sir, I haven't saw anything in the chat.
Okay, well, I'll continue to wrap up and then open up for any further questions from our group. Kind of what I've implied during the whole conversation is you and I have to have an awareness of systemic and relational dynamics and how they impact our client population. So, what systems support their change? What systems may work against their change? What are the dynamics in the systems that you work in? Again, are they trauma-informed care environments? Are they environments that have a holistic view of the client population? Are they clients that can adequately treat co-occurring disorders? Or as my colleague who's driving implied, some focus more on one, some focus more on the other, and neglect SUD or MHD. So, what are the systems and relationships that you have to move through? And how well do they impact your ability to do your job and work with the client population in this manner? And one thing we had to begin to do in Colorado is um, engage the legislative process. I believe most of you are Californians, so your state legislature is in session longer than ours is. Our state legislature is only in session from the generally first week of January to the second week of May. So a lot of these systemic changes can only be made by changing the law. So since 2011, I and a lot of my colleagues, students, and staff have been involved in legislative efforts to change the profession, change how we're regulated, and generate some laws that benefit the client population. It's not just one of these things, it's all of these things that need to be impacted by mental health professionals. Unfortunately, a lot of clinicians have not been actively engaged in the legislative process. 3 years ago, at the National Association for Addiction, Alcohol and Drug Abuse Counselors, NADAC, the professional organization for addiction counselors, it was held in Denver. So I gave a presentation, a workshop called How Clinicians Can Influence Public Policy Rather Than Being a Victim of It. And Dr. Rivas, both Dr. Rivases presented at the same conference. Their workshop on socioeconomic issues and my workshop on public policy were both packed. So it's an interest that clinicians have. It's an area that's supposedly assigned only to social workers, but all mental health professionals can engage the legislative process. The first thing to do is find out who your state senator and state representative is and just go meet with them and have a conversation. Because of COVID-19, most of those town hall meetings and appointments are now virtual. So I found it easier to reach out with virtual reality than it is to drive downtown to the Capitol in Denver and pay $16 to park. So getting out of your offices and doing something other than sitting in a chair and talking to folks about quote unquote issues and engaging in the external systems like the legislative process is another way. Going back to what some people asked about changing language, in 2004, we actually had a state senator introduce a bill to change language about how healthcare professionals talk about clients. Rather than calling them schizophrenics and bipolars and borderlines, the law actually dictated that we had to refer to them as persons with symptoms, bipolar symptoms, schizophrenic symptoms, substance use symptoms, rather than calling them disorders, which of course is shaming and demeaning. And I tell clients and even students and supervisees often, shame and guilt are useless emotions along with worry. They have no psychological value for our growth and enhancement and are designed basically by systems and people that want to control us. So I ask people, when you feel ashamed or guilty about something, the first thing you want to ask yourself is, internally or externally, who's trying to control me right now with these feelings? So they have no use uh, in the treatment of any disorders by mental health professionals. But unfortunately, as the theme of this conference has indicated, they're still too big a part of our field and the culture in terms of the client population that we work with. So I would say adopt your state senator, adopt your state representative like we did, develop a relationship with them, and then you become, quote unquote, their mental health professional. They turn to you for advice and they ask you to come and testify as an expert on behalf of legislation that they have drafted or legislation you yourself want to support. So I found that to be the most effective way rather than just sticking our face in a textbook or contemplating these issues without taking direct action. So those are the points I wanted to make today. I see we still have 10 minutes left, so I'm happy to address questions, comments, or concerns that you may have, or in the time that we have, expand on some of the points that we made. So I'm going to ask you again. Comments, questions, concerns that you want to throw at me while you got me in the time that we have left.
I got one.
From 11 to 14, Dr. Rivas. So
Okay.
What's there in the chat room?
First one is from a student, says, I am an MFT, or sorry, postgrad. I am an MFT trainee. How would you respond when a patient or client makes a comment about a trainee's lack of experience?
Oh, well, again, that's a tactic to make you feel less powerless and to distract you from holding them accountable to their treatment plan. I have multiple ways to respond to that, but often I will say something like, uh, I have a degree, I passed a national exam, I have more experience providing services than you have consuming them. So rather than try to make me feel less than, do you want to work on your issues or not? Because you have to do the work. I merely facilitate and coach you. This is your life and your treatment plan. So don't let anybody try to make you feel you're not good enough, because that's tactical to shift the power in the relationship. That's any relationship, but that's definitely the therapeutic relationship. Does that answer your question?
I believe it did.
Okay. Any other questions, comments, or concerns? Spencer says absolutely.
Yeah.
Okay, very good. Any other questions, comments, or concerns?
I have a question.
All right.
Sorry.
Our mobile clinician. What's your
Yes, driver here. I was curious. I'm not sure how many people from my cohort are in here, but I'm currently, my specialization is vocational rehabilitation.
uh-huh.
But I really want to actually work with teenagers, and so I was curious if I unfortunately I missed the first 10 minutes, but
Oh, that's okay.
I was curious if you've had any experience working with teenagers or teenage substance abuse and how that differs from adults.
Oh, it differs quite a bit. And yes, I do have some experience. I've also raised adolescents. So I have some personal experience with that. Only issue with that is I tried to raise them to be self-sufficient, autonomous, reliant adults that could begin the great adventure of life at 18. And then I bought them luggage for graduation presents. So I worked very hard not to prolong adolescence in my own family system. Uh, but issues that come up clinically are, of course, the brain isn't done yet. The research shows that at best, 26 is the age where the brain has completely coalesced, though some research shows that the female brain develops as much as 5 years earlier than the male brain, which explains some of the relationships you women have had. Uh, so because of that, adolescents are more susceptible to the brain damage related to substance use because their brains are not done yet, to put it in a colloquial sense. Peer pressure is a significant factor in adolescent substance use disorder. So, working with clients to develop sufficient ego strength to resist peer pressure from their cohorts is a significant issue. The research shows most common drugs that adolescents abuse involves alcohol and THC, probably because it's the most accessible to someone at that age. So there's quite a bit of literature available about how to work with adolescents with substance use issues. The problem is for some of our adolescent clients, their mental health disorders are triggered if they're inherited once they use a substance. So the research shows, we've heard all the talk about gateway drugs, but the research shows that some young adults can have a latent psychosis stimulated by use of particularly alcohol and THC. So the onset of substance use disorder actually parallels the onset of mental health disorder. The population most in danger, 15 to 24. The other problem is that if someone has had a onset of substance use disorder, mental health disorder, or trauma, they're stuck developmentally at that age. So you may have a client that's 17, but developmentally, their emotional intelligence, their coping skills, their sense of self is actually pre-adolescent. And it's also true for adults. You can have adult that's chronologically 40, but because they had substance use, mental health, and trauma issues earlier in the lifespan, psychologically, they may only be 12. So one thing that's often absent from our screening and assessment is looking for arrested development on the part of our client population because of what they experienced earlier in the lifespan. Okay. Does that answer your question?
Yes, thank you so much.
You're more than welcome. Well, Dr. Rivas, how are we on time?
I have 11:28, so
Ooh,
we're right at time, I
ooh.
believe.
Well, I don't know how profound I can be in 2 minutes, but are there any closing questions, comments, or concerns based on the topic we discussed today? Anything else in the chat room?
Um,
Okay, good enough. Well, my handout has my email address. Leslie Institute at cs.com is my email address. Of course, you can always Google Colorado School for Family Therapy, and the school's website will come up with our programs that we have that you can even do by Zoom or distance learning. You Google my name, of course, stuff will come up on the website, but don't believe everything you read about me on the internet. It's not true. Okay, anything else, Dr. Rivas?
I got a lot of thank yous and great information. And I agree. Dr. Leslie is always a pleasure to have speak, and always a pleasure to have part of this. Very knowledgeable. And I appreciate your time today, and I appreciate everybody coming to the breakout session. I hope you learned a lot. I know every time I hear Dr. Leslie speak, I do, and it gives me things to think about when I walk away from the session. So I wanted to thank you, sir, for participating and presenting this.
Well, I want to thank you and Dr. Beta for inviting me, and to all of the participants in our presentation today. My cell phone number's on my website. You have my email address. Feel free to contact me if there's anything else you want to explore in terms of what we talked about today.
And I put your email address back up on the screen.
Yep. Cell phone too. Okay, thank you, everybody. Dr. Rivas, can you give me a quick call when we get done?
Yes, sir.
Okay, thank you much.
I will. All right, everyone. Thank you very much, and you have a fantastic day, and I'll see you all later.